Okay. I believe I have started the live stream. Yep, I have. All right, we can go ahead and get started. It's 7:02, and I believe people are still joining us. Okay, good evening, everyone, and Happy New Year. And thank you for joining us tonight. My name is Ravina Nimbalkar, and I'm the Executive Director at NAMI Santa Clara County. Before we start with our general meeting, the first general meeting for 2023, I'm going to go over some updates at NAMI Santa Clara County. Our helpline is up and running from 10 a.m. to 6 p.m., Monday through Friday, via phone as well as email. Our after-hours family support is available on evenings and weekends. All the support groups are listed on our website, which is www.namisantaclara.org, and offered over Zoom currently. The educational classes, such as family to family, familiar to familiar, persona to persona, peer to peer, provider education class. For getting more information of what the schedule is, you can call our helpline number, which is 408-453-0400, and select option number. And you can get on the interest list once you call that number. NAMI Basics is on demand on our website, which is something that you can take at your own pace. Okay. And same with the NAMI Homefront, which is online at demand, and you can take it at your own pace too. The community peer program continues to match by hospitals as well as referrals. And if you need more information, you can call a helpline number, which is 408-453-0400, and select option number 1. Okay, so our topic for a general meeting today is an overview of Care Code with Stephanie Welsh. Stephanie is the Deputy Secretary of Behavioral Health for California Health and Human Services Agency. In this position, Stephanie acts as a senior advisor to the Secretary of Cal-HHS and other state departments on behavioral health policy. In addition, Stephanie builds bridges across the various government sectors with the stakeholders from diverse perspectives. Stephanie has over 2 decades of experience in mental health policy, program administration, evaluation, and advocacy at both state and county level. She holds an MSW from University of Southern California and a BA in sociology from the University of California, Davis. So I'm gonna hand it over to Stephanie. I do want to mention that we are live streaming this presentation on our YouTube channel. This is a webinar mode, so feel free to post your questions in the Q&A section, and we also have the chat options open for you. So you can feel free to chat there, but if you can post the questions in the Q&A section so that we can address all the questions towards the end of the presentation. Over to you, Stephanie.
Great, thank you. Well, I'm happy to be here. I apologize, I'm kind of tinkering with my presentation, but we have some new technology here, so you can see that we have some captioned comments are at the bottom so that you can follow along if it's easier for you to hear me and follow along in that way. So thanks for the nice introduction. I can't necessarily see faces out there, but I'm glad that I could reach out. I think it's really important for us to do our best, even in these really early stages of implementation, to be available to open lines of communication. So this is really a first step at that. And I do hope that at the end of today, whether it's in this interaction or a future interaction, we can get some more ideas from all of you about the kind of information that we might be able to produce and disseminate that would be helpful. So today I'm specifically here to talk about the CARE Act, as was mentioned. Now it's not going to go forward. Okay, there we go. Today's agenda includes an overview of the Act. I think it's really important to make sure we kind of walk through what the process is for the Act. talk a little bit about the elements of the Act that are unique around accountability, as well as a variety of different forms of technical assistance that is mandated to be provided to the participants and the people who are implementing care. Some frequently asked questions, and then an update on some implementation activities before we kind of open it up to questions and discussion. So first, let's start with the CARE Act overview. So the Community Assistance, Recovery, and Empowerment Act was intended to really be a new compassionate process to use the civil court process to provide an additional tool in the toolbox to get access to care. CARE aims to deliver behavioral health services to the most severely ill and vulnerable, while preserving self-determination to the greatest extent possible throughout the process, most notably seeking community-based living. CARE is an upstream diversion to prevent more restrictive conservatorships or incarceration. In fact, when we were in the early stages of thinking through what would become CARE, really two of our primary goals were to reach people before there was a need for a conservatorship, and to reach people before they had to unfortunately be incarcerated in order to get access to care. CARE is based on evidence that demonstrates that many people can stabilize and begin healing and exit homelessness into less restrictive and community-based care settings. And something that's very unique to CARE is that its success really is dependent on both the participant in care as well as the system being successful in delivering appropriate care and services for the individual. So CARE is different from some of the other tools that we have in our toolbox. First, it's fundamentally different from LPS in that one of the primary and core goals of CARE is to not have to rely upon custodial settings or long-term involuntary medications, or even long-term involuntary housing placements, or I would say treatment placements. Unfortunately, that ends up being some of the outcomes for individuals who do experience conservatorship and or potentially may be conserved for longer than necessary because there weren't any community-based alternatives that could support the high level of needs that individual has. CARE is also different than Laura's Law in several important ways, although AOT, Laura's Law, is also an important tool that we have in our toolbox. But CARE is a little bit different. One of probably the most critical differences is that a petition may be initiated to the court from a variety of different entities and or I should say people who are associated with different systems. They could be first responders, they can be family members, clinicians, physicians, behavioral health providers, etc. And there are provisions within the Act to ensure that only credible petitions are pursued. The need for multiple negative prior outcomes to be experienced in order to meet the qualifications are not present to the same extent as they are in AOT. And probably the one that is really important in terms of policy is that both local government and participants who are in the CARE program are working together to complete the care plan, but also be held accountable to that care plan. And we'll talk about it in a little bit. Lastly, and importantly, in an area where ongoing, I know we'll really be interested in guidance and input and feedback from our NAMI partners, would be this new kind of concept we're coming up with someone to play the role of a supporter who's really there to help assist, identify, voice, and really center the individual's care decision in their care plan and in their graduation plan. And if during the time that that individual is in care, they want to prepare a psychiatric advance directive, they would be the person on the as part of the overall process that really can help with that. So the criteria for a care respondent, I think we really are taking the time to kind of go through this in a lot of detail because it is a significant amount of elements that make someone reasonably considered for care prior to a clinical evaluation. So first, let's just start with the petition. So a petition is filed by a family member, a roommate, provider, clinician. There's a list in the statute that kind of talks about these individuals. And we really thought about individuals who were coming in constant contact with someone who may have an under or untreated mental illness, specifically schizophrenia or another psychotic disorder. So that is identified. The petition must include an affidavit from a licensed behavioral health professional or evidence that the respondent was detained for a minimum of 2 intensive treatment under what is known as a 5250. So as you may be aware, a 5250 is a 14-day hold. That's when somebody who may be on a 72-hour hold has not stabilized to the point where they no longer meet the criteria for a hold. And I think this is important information to know so that we're clearly articulating, what some of the expectations are for individuals to meet this criteria. The petition is promptly reviewed by the court. I mean, there are a lot of very tight timelines in the care process, and that's intentional because, of course, people are experiencing untreated, very serious and significant mental illness. They may be unhoused, and we really want to expedite the process to get them into the care that they need. So if the petition is reviewed by the judge and it does not meet the criteria for care, the elements of the petition are less than adequate, the petition itself can be dismissed. If the criteria is met, the court will order the county to investigate and file a written report. And this was something that we designed while we were working in partnership with our county implementers, and most notably the county behavioral health departments. And there's a couple of real significant benefits to this. First, the county will go out and submit a written report with the findings and conclusions they have in the investigation, along with any recommendations. If the county is making progress with engagement with this client, an additional 30 days can be provided to continue to support any progress that's being made to enroll the individual in involuntary services. The court may refer the individual. So I think that was really important, because something that we heard throughout the design phase of care is that even though the vast majority of people ultimately who will probably have a court-ordered care plan are individuals who may be treatment resistant or have not been compelled into treatment. And I don't mean compelled as in coercive. I mean, there might not have been anything compelling that we were offering. We weren't offering housing. We may not have been offering services in the location that the individual wanted them. Maybe the individual didn't want to discard of their pets or other possessions. And so the idea is really to have this focused engagement with the hope that the individual will want to go into voluntary services. And we'll come back to the process if that's not the case in just a moment, but did want to note here that there are 2 other ways that an individual can get referred to care that are not necessarily the petition process, and that would be a court referring an individual from an assisted outpatient treatment proceeding and or conservatorship proceeding. And this is really important to us because I know I hear a lot of kind of feedback and or questions around, is care one step towards conservatorship? Like, is it intended to be used to expedite conservatorship? And we would really argue that that's not the case at all. And we do actually think that care will function to help people leave conservatorship and go into a care plan as a good way to step down into more independent community-based living. And then secondly, a court may also refer an individual who's found incompetent to stand trial from a misdemeanor proceeding pursuant to the existing penal code. And this is really important because, as we know, many individuals still, even if it's just a misdemeanor charge, may be sitting in an incarcerated setting And this would be a potential opportunity, one of several options that the judge does have to get someone into care. Some of the other options that exist currently are things such as referring someone to AOT or referring someone to a conservatorship. We want care to be an accessible tool for various different situations, and care would potentially be a really good tool as an alternative for somebody who is incompetent to stand trial for a misdemeanor. Next slide. Oh gosh, I'm sorry, I moved my own slides. I apologize. It's been a very long day, folks. So care pathways, petition to the initial hearing. So now we're kind of more focused on moving forward. The petition has credibility. The county has done their assessment, and we're moving forward with the court reviewing some additional information. So if the court determines that voluntary engagement is effective, that the county doing that outreach has worked, and the individual is enrolled in behavioral health treatment, the court will dismiss any further proceedings. If the court determines that the respondent is likely to meet the criteria and engagement is not effective, then the court will set an initial hearing within 14 days. This is to really get the court orders going. The court will appoint counsel and orders the county to provide notice of the hearing to the petitioners and others as directed by the statute. At the initial hearing, the court determines whether the respondent meets the care criteria. If so, the court orders the county behavioral health agency to work with the respondent's counsel, the care supporter, if the individual has decided that they would like to have one, to engage in behavioral health treatment and to determine if they're able to enter into a care agreement. So this is really where a lot of the kind of involvement of the court starts to begin. Even though the court is reviewing the petitions, etc., the first kind of part of care is really the engagement with the client and the kind of deployment of county behavioral health to start that engagement process. So there is still a case in which once the court has ordered this, that the individual says, and I mean the respondent, the client or the consumer, that they want to have a voluntary settlement agreement, and they're interested in entering into that. And this is very similar to what's in a care plan. The agreement would include a range of community-based services and supports, things that are clinically appropriate, stabilizing medication, housing, other supportive services, etc. And the court will set a case management hearing within 14 days. So even though it's a voluntary care agreement, it will be heard by the court. So if the court finds that the parties have agreed to the care agreement and the court approves it, the court will set a progress hearing for 60 days. This was important to us because, again, we want to make sure that it's working, that this voluntary agreement is something that has really been a success for the consumer as well as the care team. If the court finds that the parties have not reached a care agreement, then the court will order a clinical evaluation for the respondent. The court will order the county behavioral health agency through a licensed behavioral health professional to conduct that clinical evaluation. And the county has up to 21 days before there will be a hearing to go over what was found during that clinical evaluation. So if at the clinical evaluation hearing, the court finds that the respondent meets the care criteria, the court will order the development of a care plan, which includes the same elements as a care agreement. But if the clinical evaluation finds that this person does not meet the criteria for care, then the issue will be dismissed. For most, at this point in the process, they're most likely to meet the criteria for a care plan. And so the plan itself will be developed with the respondent, who is the consumer, their counsel, county behavioral health, and if desired, a supporter. A hearing to review and consider the approval of the proposed care plan will occur within 14 days. Again, really trying to keep some of these timelines as tight as humanly possible. After reviewing the proposed care plan, the court may issue, and this is really important, any orders necessary to support the respondent in accessing appropriate services and supports. That includes the prioritization of those services. Meaning if there is a wait list for a really, really important treatment program, the court may consider that somebody in care might need to be expedited into that program because of the severity of their condition, etc. The issuance of the order approving the care plan begins the up to 1 year of the care program or timeline, and at intervals no less than 60 days during the care plan, the court will have status review hearings. And we really thought a lot about this, and I think there's a lot of great collaboration to come in the future, but we know that for many populations, court is not a comfortable place. There may be histories of traumas that were experienced in a court process, and we really want to be mindful that we have a lot of work to do to kind of put the care in court. Doesn't mean that there aren't excellent diversion courts and mental health courts and drug courts and family courts, but we do want to be very mindful that the entire process of care court really has care at the heart of it, which is about wrapping around the person and supporting them to be successful in the community. This is not a civil process. I'm sorry, this is not a criminal process, it's a civil process. And so we hope it to be a collaborative and supportive process. So back to the slides. In the 11th month of the program, the court will hold a 1-year status hearing where the court will determine whether to graduate the respondent from the program or to reappoint the respondent. The respondent may also voluntarily request to be reappointed, but the important part of this piece is that people will not be reappointed if they do not meet the criteria for care. And I think it's unless there's it's not super likely that someone would continue to meet the care criteria after this level of intensive treatment. So then the court will review a voluntary graduation plan to support the successful transition out of court jurisdiction. And at this point, they may share the work that they did to create a psychiatric advance directive. It is important to note that once someone does exit care, kind of the graduation plan, which is kind of the care plan that's ongoing, and I know this is really important to our NAMI families, that the court doesn't have the jurisdiction to enforce that those things are still happening as they once happened in care. But we really feel super confident that in the strength of delivery of our behavioral health system and our partnership with county behavioral health, that they will be really supportive in trying to figure out sustained placements for care graduates because of all the work that has been done in the year coming up to really helping to stabilize people and support them in long-term recovery. So, this is really what their system is designed to do, is to do that level of intensive treatment and then support people to live successfully in the community with the right level of care. And so just wanted to clarify that. Okay, I know that that's a lot. I'm sure you're going to get a copy of these slides so you can read them in more detail. We also walk through some of these processes in even more detail in our FAQ, which is on our website, and there'll be some links at the end of the presentation. So accountability, I kind of alluded to the fact that care is unique in that it is not just court ordering an individual to comply with a set of directions and requirements, but it's actually ordering the county itself to comply to deliver the care that is identified in the care plan. So a court can fine a county or a local government entity if it is not complying with care. Something that was important to us when we thought about what are we going to do with the fines that we collect, it didn't make any sense to use it for anything other than really supporting that local government to have the capacity to better serve people with schizophrenia spectrum and other psychotic disorders. And so the money that is collected will go back to the local government entity to get them up to speed and par and capacity to be more successful at complying with the CARE statute. So in terms of individual accountability, if the court determines at any time during the proceedings that the participant is not participating at all, they don't come to any of the court hearings, etc., the court has the authority and may terminate the respondent's participation in CARE. The court may also have the ability to utilize existing authority to ensure an individual's safety. The court shall provide notice to the County Behavioral Health Agency and the public guardian if the court utilizes this authority. Basically, what this means is if the individual meets the criteria for LPS, it may be important, and it would be important for the judge to intervene to support that individual's safety and use the tools that they have within existing law to move forward with solutions for that individual. Under certain circumstances, the fact that the respondent failed to successfully complete their care plan shall be a fact considered in certain subsequent proceedings, provided that a hearing occurs within 6 months of the termination of a care plan. Basically, what this means is that if a conservatorship is pursued for this individual, and that's if a conservatorship is being pursued. It doesn't trigger the pursuit of a conservatorship. But if it is being pursued, that this information, if somebody was terminated from care in the last 6 months, can be a fact in the case. Next slide. Oh my gosh, I did it again. Sorry, guys. Technical assistance, data reporting and evaluation. No significant policy change can ever be successful in happening without significant investments in these 3 areas. It was really important for us to accomplish that, and hopefully with all of your help, we will do a good job and get your guidance in what needs to be provided in terms of technical assistance and what needs to be reported back to all of you to have a better sense of whether or not this is working. So technical assistance, our Department of Healthcare Services is responsible for providing training and technical assistance to county behavioral health agencies regarding the care process, the agreement and plan, and the services and supports that should be a part of those care agreements and plans, supportive decision-making, the role of the supporter, trauma-informed care, elimination of bias, the use of psychiatric advanced directives, family psychoeducation, data collection, and this training also is to be provided to counsel, so the legal aid associations and public defenders, as well as our partnership with the Judicial Council, and volunteer supporters who will be a part of these proceedings if desired by the respondent. So pretty long list of training, and I'd have to say in my nearly 25 years of being around the block in this space, like we haven't really had the ability to say, not only are we going to require that this training be had and people partake in it, we're actually going to pay for it in a really robust way to ensure that it reaches who it needs to reach with good quality. In addition, the Judicial Council, in consultation with the department, meaning the Department of Healthcare Services and stakeholders, is also responsible for providing training and technical assistance to judges about the care process, the care agreement, working with the supporter, supportive decision-making, supporter role, the role of the family, which I know is really important to you all, but also some additional things from the behavioral health side of the shop, like behavioral health best practices, what are evidence-based models of care for people with serious behavioral health conditions, etc. I'm really excited to also share, and we go into some detail in a couple of slides, but we've, since early fall, really, since the signing of CARE, we've been meeting regularly with our partners at the Judicial Council. And really are kind of attached in terms of wanting to move forward with the same kind of messaging. The kind of training on these issues for judges doesn't have to be dramatically different than it is for county behavioral health or other health and human services providers who will be participating in care. So I think it's really exciting for us to move forward providing that service together and in partnership. This slide, data and reporting. So our Department of Healthcare Services, again, is responsible for developing, in consultation with input from our stakeholders. I want to make sure that you guys see here very clearly that these reporting requirements and how they get reported should really be weighed in on by individuals of lived experience, families, racial justice experts, disability rights groups. Really need to have good, strong reporting so that we can find out what's working and not working, and probably more importantly, even get insight as to what to fix to make it work better. DHCS will provide information on the population served, demographic data. They will also report on outcome measures to assess the effectiveness of the CARE Act model. These are some of the things that are identified that we will study. So improvement in housing status. Did they gain housing? Were they able to maintain housing? Reduction in emergency department visits and inpatient hospitalization, reduction in law enforcement encounters and incarceration, most certainly reductions in involuntary treatment and conservatorship, and reductions in substance use. We will also have, as part of the report, a health equity assessment of the CARE Act to identify demographic disparities based on demographic data to inform disparity reduction efforts. We are incredibly excited about this. I think I really want to underscore that when we did roundtable visits throughout the state, we even had the opportunity very briefly to be in Santa Clara. We heard loud and clear from people, and the evidence is, the data is undeniable, that Black and Brown communities, particularly African-American men, were overly represented in carceral settings with mental health conditions, and also were more likely to be unhoused. And we also know that there's documented evidence that African-American men are overdiagnosed with schizophrenia. So this really, instead of shying away from those realities and those numbers, we're going to take this as an opportunity to study them in California and try to figure out what we're doing and how we can start addressing some of those disparities. So in addition to regular reporting, we also have the opportunity to be a part of an independent research-based evaluation of the effectiveness of care. We really want to use this evaluation to highlight and study racial, ethnic, and other demographic disparities, as I just mentioned. I think we're particularly interested to try to do some causal analysis or descriptive analysis to talk about how the care is impacting disparity reduction efforts, which are one of the top priorities of this particular agency. Moving forward in all of the things that we're doing in the behavioral health space. And so the preliminary independent evaluation is due to the legislature 3 years after the implementation of the CARE Act. So that would be, I think we have to think about this because we have 2 different dates, which we'll talk about in just a moment, those for our first cohort and those for our second. But really, really excited about working with all of our stakeholders, like all of you, to try to figure out what are the kinds of questions we really want to ask with the evaluation, what's really meaningful in terms of knowing that we did a better job. So some FAQs. These are just some of the top questions we get, and we're wrapping up here and getting ready to open it up for questions. So maybe this will perk your thoughts a little bit about the kinds of questions you may have based on some of the questions we've been getting from others. So how is self-determination supported in the care model? Well, first, we want to make sure that folks know that each participant or consumer is offered legal counsel, and they also may choose a care supporter in addition to their full clinical team. And we're still really in the design phase of what the supporter can do, but the supporter is an enhanced role in addition to what would be appropriate on a team like this, which of course would be peer support specialists, and also care clinicians that are able to do work with the family, as we mentioned before. So each, and then I also would be remiss in saying that it's highly likely that a care participant would want to choose a family member or a loved one or friend to play the role of the supporter in their care process. Each participant develops a care agreement or a care plan in concert with the behavioral health teams. And so this is really a co-pilot process. And the care agreement, while there are court orders in the beginning, it's not really a static thing. I get that question a lot. People's needs change throughout the course of their treatment, and they can always maybe go back and the individual could talk to the judge about some tweaks that are being made to the care plan in order to better achieve the outcomes that the individual and the clinical team want to achieve. And then also, we're really hoping that we can work with in partnership with organizations like yours and others to really kind of uncrack this nut that is the Psychiatric Advance Directive. It really has the potential to empower individuals to clearly identify how they want someone to manage any future episodes of a mental health crisis that they have. But we also kind of have to make sure that it's being used and the technology is there to make sure that those things are in place. But we are really excited about having care as an opportunity to really dive into how to better use these psychiatric advance directives. So why isn't care inclusive of all behavioral health conditions? You know, we do get this one a lot. Care is obviously very focused on a certain class of diagnoses that are both severely impairing, but also highly responsive to treatment, and in particular, stabilizing medications. Being able to manage what I guess we all know, many people I'm sure on this call know as positive symptoms that can be so really debilitating is really responsive to some of the newer medications, especially in the way in which we're able to be more specific with our dosing so that people don't feel so over medicated. Probably a little bit too much color commentary on this, but we really have made significant advances in treatment that we really honestly don't use as much as we should as evidence-based practices. And then also the other really important part, which I get to be really a part of every day in my role as Deputy Secretary for Behavioral Health, is we are in the midst of a massive, broader behavioral health redesign being led by the administration. And we felt that there were several other things that we were doing for other populations in these investments, whether it be the Children and Youth Behavioral Health Initiative or the work that we're doing with implementing 988, that care really needed to be focused on those who were the most at need, who suffer the most when they go untreated or undertreated. And that's our rationale for that. What is the role of housing in care? Housing is a critical component of care. We know that if individuals who are participating in care are not stably housed, they cannot focus on what is in front of them in terms of caring for their mental health condition. So it is incredibly important. And as I mentioned before, when a judge is reviewing a care plan, the judge can make orders. Individuals who are served by care may be prioritized for available housing. That's not really on the slide, but I just wanted to underscore that as a discretion and an authority that the judge has. Did want to point out, though, that we have $1.5 billion in interim, or what we call bridge housing, which is clinically enriched housing services. Think of a really wonderfully clean board and care facility that has additional enhanced staffing to really support people with to be successful in that living setting. That's really what we think of as clinically enriched housing. And just as a quick update for this, we do intend to make the announcement on the first set of allocations for behavioral health bridge housing early in February, if not potentially sooner, but very, very soon, we will have that information out on how those resources can be used. And we also will be providing extensive training and technical assistance to the counties in this space as well. And I don't have to tell any of you this, especially since it was budget day. That's probably not your day job in a way that is like mine, but I spent most of my day in budget briefings. And over the last several years, we have invested over $15 billion in addressing homelessness. I guess two things to say about this as it relates to our population. It's challenging because while being housed is essential to health, housing is kind of complicated when it comes to behavioral health conditions, because some of our housing is really what we would call a facility or a residential placement. But I like to really call these opportunities more like, what is the appropriate community placement for an individual? It may be long-term permanent supportive housing. It may be living with mom and dad as long as mom and dad get some respite. It also may be, I'm going to be in an adult residential facility for most of my adult life. There's no wrong answer. It's what works best for the individual. But we do need to really work with our housing and homelessness providers to ensure that people with behavioral health conditions, and in particular people with behavioral challenges, are not being excluded from rightful housing opportunities. And we'll continue to do that work in many ways through our conversations we have with our fellow state departments and agencies while implementing care. So why is there a court involved at all, especially after those words I shared at the beginning about some of the concerns that people had about, you know, how intimidating a court process can be. So courts, quite frankly, are often already in the crosshairs of the lives of those suffering. I don't really need to tell this group that at all. Probably many of you have unfortunately had loved ones who've had to go through the criminal justice system in order to get access to mental health or substance use care. And so courts are already doing this work. It's just, unfortunately, they're doing it on the criminal side of things. And we really want to move this to the civil court. And we want to serve people before they end up in the criminal court system or in conservatorships. So CARE really is a vehicle for collaborating and coordinating with our court partners. It's not about compliance. And so we're really trying to model and build those relationships at the state level between our agency and our judicial council partners. So in the case that a client can't participate or the government entities can't implement an appropriate person-centered plan, that's really when the court deepens its engagement and I would say oversight. But we don't anticipate that that's going to be the norm. We anticipate that the norm is far more going to be like a collaborative court setting where everyone is working in partnership to support the success of the client involved. So how can we address racial bias? As I mentioned before, there are well-documented racial inequities in clinical diagnosis, homelessness, and justice system involvement. We acknowledge these and we are addressing them in the formative design of the program. As I mentioned, some of the work we're going to do in the evaluation space. We are really wanting to use standardized tools for assessment and evaluation so that we can monitor and look for features that may drive racial bias. There will also be implicit bias training for individuals who participating in the care process and participate in the implementation of care. And it's important to really bring to the awareness these drivers of inequity and their perpetuating role. And so that'll be, we'll be really eager to work on that in partnership with all of you as well as with the Judicial Council. And I do think that as part of today's message being here is that we want to really want to continue to engage with communities and our stakeholders, especially in these really formative days of care, but also ongoing. I'm going to talk a little bit about the CARE working group that we are setting up that will meet regularly over the next 5 years to monitor the implementation of CARE. So implementation activities. First, as I mentioned, there really are two phases of implementation. The first is phase one, and that consists of 7 counties that represent about between 25 and just shy of 30% of the state's population. So Glen, Orange, Riverside, San Diego, Stanislaus, Tuolumne, and San Francisco. They will be implementing by this fall, October 1st, 2023. The other counties will begin implementation no later than December 2024. There's nothing stopping a county from wanting to start before December 2024. And also the only way in which a county will not implement by December 2024 is if they are granted additional time by DHCS because of certain circumstances that we are in the middle of working through right now. And unlike AOT, until recently, counties do not have an option to opt out. They must provide this care process to constituents of their county. So what have we done so far? What are our roles and responsibilities? On behalf of the California Health and Human Services, just quickly running through some of our responsibilities. We are the lead coordination efforts with and between the Judicial Council and DHCS. The Judicial Council and the Department of Healthcare Services really are the state implementation engines supporting the local courts, supporting local county behavioral health. And we're here up at the state level, making sure that the policy direction that's happening at the state level is really working at the local level and keeping all of those lines of communication open. So in order to do that, we want to engage with cross-sector partners at both the city and county level, but also individually and through collaboratives and convenings. We've been having lots of meetings with different groups who have particularly important roles in implementation, just so that they are better understanding what's ahead. We really want to coordinate with partners from a diverse set of stakeholders versus including regular meetings, kind of thinking through that a little bit, also thinking through how to work with a vast majority of stakeholders like you on a state basis. We want to support DHCS in its training and technical assistance and evaluation responsibilities. We'll be supporting them in the success of the Behavioral Bridge Housing Program, monitoring housing related needs throughout implementation. We want to hear if it's not working. And then we also are really the central point for communication. We have established a care website. We have a listserv. We'll get to some of those other things, but we also kind of work with the media, work with the legislature and other stakeholders to answer their questions, but also as we get closer into implementation, really be more proactive with the media and community engagement. One of the primary vehicles for us to fulfill these responsibilities is through our facilitation of the CARE Act working group. The working group will begin its work fairly soon. We are in the process of getting out the secretary's invitations for the CARE working group right now. And they really serve as the primary mechanism to receive feedback from partners to support successful implementation and to help key constituents understand the policy and program progress that we're making, and to use the CARE work group convenings as a way to disseminate timely and accurate information. So we really envision 20 to 25 members. The statute kind of gives some broad strokes of which organizations and perspectives are important to be on the CARE group. I would say that overarching, the main theme is people are going to have different opinions and different ideas, and that's great as long as you come to the table and we try to solve problems to ensure that we get better outcomes for people. That's really what we're doing at the table. So we're going to have representation from families, from behavioral health providers, from judges, legal counsel, peer organizations, disability rights groups, racial equity stakeholders, and housing and homelessness providers. Really, it's just a broad group of people who have a lot of expertise who can help us be successful. So some of the specific things that the group will provide feedback on will be the design of the annual report, the design of the evaluation plan, help us kind of think through and tackle some of the challenges associated with data collection and reporting. They will also be reviewing training and technical assistance that is provided to counties, volunteer supporters, legal counsels, judges, etc. We will use it as a forum to get updates on the county implementation process. We will use it to troubleshoot around housing access, and generally just use it to troubleshoot on other emerging issues that will come up, I'm sure, in the course of the first 5 years of implementation. Our Department of Healthcare Services, as I mentioned before, their main role is in training and technical assistance. They also will be doing the data collection, reporting, and managing the independent evaluation. And then they will also monitor the fund that I mentioned before, if there are fines and fees. And lastly, the Judicial Council has a lot of very significant roles and responsibilities as our core partner in this. So they, of course, participate in interagency planning and communication at the state and local level. They have already disseminated an initial CARE Act procedural memo. So just really to try to inform courts about what CARE is and act as a resource. They also really function as a communication hub for their courts, information sharing across the courts, collaborative platforms. They are helping to develop funding allocations for the courts. One of the things they're really actively doing right now is developing the rules and forms for CARE. So that would be something like, what does the petition look like? What do the instructions look like to fill out the petition, etc. They are responsible, as I mentioned before, for training our judicial partners, training folks who are providing legal representation to CARE folks. They work with all of their self-help centers to make sure that they have information so that they can assist people who may need help doing things like completing petitions. And similar to DHCS, the court also has a significant role to play in providing guidance around data collection and support around successful data collection, which will be really important. So that's it for the formal presentation. I'm right here is the direct link to our website on CARE. We try to keep it up to date with new information. If you are not on our CARE Act listserv, you can send an email to that email address right there, and we'll put you on the listserv so that you stay in the know. That's also the best place to get any updates related to the CARE Act working group, which will be a Bagley-Keene governed group. So it's really quite a public forum for engagement. So thanks, I'll pass it back over to you, and I will stop sharing my screen.
Okay, great. Thanks, Stephanie. So we do have some questions, and I'm going to go over them now. So the first one is, I have a family member who lives in Santa Clara County that would probably meet the CARE program requirements. He has been off of medications for a few years and has been psychotic for a long time, paranoid, in brackets. I've tried to get him into behavioral health facility. He's insured by Kaiser, but he has refused and the police has not cooperated. Now he's in jail and has felonies and misdemeanor charges against him. If the family is not planning to count on the county of resources, can we petition the court to place him on 5250 in the Kaiser Behavioral Health Facility?
Wow, that's a really specific question. I'm not sure I'm going to be able to answer it all directly. A couple of things. Let me get back to the intersection with Kaiser, but what I would say as a family, first, CARE is not implemented yet. So I think part of having some of these conversations is thinking through, how do we use this moment to make sure we're getting out education so that people can get access to what's available now? So what I would say to that is, if the individual is appropriate, and they may be appropriate for your local felony diversion program, that's something that they should look into. And I do believe that you that for that program, you shouldn't have to go through county behavioral health to get the referral. You would actually go through the court process. So through your loved one's public defender, or it might even be something that you could take up directly with the district attorney's office, whoever is, prosecuting the case. So that's that, to make sure that I want to make sure that you know that you can ask for those things. In terms of what's available under Kaiser and what's available under county behavioral health, I still think it's good to first contact county behavioral health and see if they can assist with you getting access to the resources that you need that are delivered through Kaiser. I know that's not being super specific, but they may be able to assist in that case. That is if your loved one is interested in voluntary care. So I know that that's a big if. And so, it might be appropriate for your loved one to be a candidate for AOT or for Laura's Law, which is now available in your county. I don't know how quickly it's been up and running, but your county does technically have that program, and it might be a good option for you. So those are a few suggestions, if that's helpful.
Okay, thanks, Stephanie. Okay, so the next question is, I've been told that support services are overwhelmed, frustrated with being understaffed with too many clients, unable to find placement in a timely manner for treatment and longer-term supported housing. My question is does the care program have the staffing and housing to support the high need?
Yeah. I mean, I would be remiss to say we don't have a crisis on our hand. I would say specifically a workforce capacity crisis. Care is phased in implementation, and I think based on some of the recent year investments, we have just made significant investments that I do feel like we're starting to see the tables turn a bit in terms of increasing access. Things are no wrong door approach with CalAIM. And I also really want to underscore, as we've shared with the counties, we still believe that on a statewide basis, there will not be more than about 12,000 people at the most who will qualify for care. Mm-hmm. Again, that's because of the really strict criteria that I shared for you guys. And that partially is because we really believe that this particular population is uniquely situated for a very, very robust care plan that includes housing. It's what's going to keep them from repeat hospitalizations, homelessness, and ultimately institutionalization, whether it be in jail or the state hospital system. And so we are in just today's budget that we announced, we have additional resources that we're giving county behavioral health on an ongoing basis to do some of the legwork, some of the non-Medi-Cal billable type work, non-clinical work, to really work it and make sure that these clients are getting to court, and that they're doing the reports, and that they're doing really aggressive outreach. And frankly, what we know about aggressive outreach in this space is that we really have to lift up our unlicensed but trained professional behavioral health staff, our peers, our community health workers, individuals who are trained in engagement and effective outreach, homeless outreach workers, etc. And so I think really that's going to be the engine of the new workforce to do this work. They're also going to be hitting the pavement and trying to get those housing placements. I understand that $1.5 billion, I mean, in California these days does not sound like a lot of money, but we really feel with the right training and the right fostering of relationships with providers, as well as fostering the relationship with the community, that we can find a way to get placements for these individuals in their home counties. I know that's a particular challenge talking to folks who live in Santa Clara County and the incredible cost of living. But I do think with the help of organizations like yours, helping people understand that people with serious mental illness are just like any of us, and that they deserve to live in the community in which they were raised and want to live in, is really going to be helpful. It's not going to be easy, but I'm not totally convinced it's all about capacity as much as it might also be about will. I also, just to tie this back to things that I hope come up at the CARE working group, to have it be a public body where people come and do say, listen, I tried to get a placement for this individual with 5 different providers and I got turned away from all 5. To me, that sounds like discrimination. And I think that that's potentially happening. We've got to find ways so that it's not so easy for providers to turn people away, that and also that we give them the support and resources that they need to successfully house people who may have more challenges. So I continue to be hopeful.
Awesome. The next question is, you've mentioned that this is a civil court kind of a corporation between petitioner and the respondent. But what if the respondent refuses to cooperate and we need them to be placed at a mental health facility in order to clear their brain from psychosis and realize what has happened to them?
Yeah, these are really hard conversations. We elected as part of CARE to not make changes to the existing LPS conservatorship roles. So for example, it sounds like, I'm going to extrapolate, but let's say that your loved one has untreated psychosis and they meet the criteria for a 5150. If this person is known to, if this is known to the court, maybe it comes out of the clinical evaluation, maybe it comes out is something that might be an issue that comes out of some sort of an assessment. If there is evidence that the court is given that documents that this person meets the threshold for certain triggers, for lack of a better word, under the LPS law, then the judge is going to do what judges do, and that's to do the right thing under the law and get access to care for that individual. So, but that's at the judge's discretion to use that existing law. I'm not sure if that's suffices the answer to what your current situation is. I do think I would always encourage you to call the access line in your county and explain to them what you're experiencing, and see if they have any suggestions on where to engage your loved one. They can do all sorts, and this is not a bridge to a conversation about mobile crisis and developing peer and clinical mobile crisis response, but it's such a great example of when that system is fully functional that you would be able to call especially in Santa Clara County, call your local 988 number and get access to a clinician and peer-based alternative crisis response teams who may be more successful engaging your loved one so that they can do an assessment. Yeah. They can offer them voluntary services, or they can do an assessment because the person is so psychotic that they would meet the threshold for some sort of a hold that would help them get stabilized. So, and I really do bring up that example because these various different initiatives that we work on, they really might seem patchwork in the way that we explain them to all of you, but they really are in design with each other. Whether it be the build out that we're trying to get to with mobile crisis response, or the work we're doing to get the IMD waiver exclusion lifted, all of them are really necessary, or both of them are really necessary to be fully functioning and working well to have the outcomes we know we're going to be able to get with CARE. So sorry if we're going off on a little bit of a tangent, but I hope that's helpful.
Okay, the next question is from Senator Jim Bell. What changes to CalAIM are being considered? And he also complimented that you're doing a great job.
I didn't catch the first part of the sentence though.
What changes to Cal-AIM are being considered?
Oh, yes. So two really exciting new pieces, Senator. One I just love. We are going to be putting in an amendment to our Cal-AIM waiver so that we can get coverage for 6 months of rent for people who are recovering from a psychiatric hospitalization for a more serious condition. So, I mean, that's so exciting. So, I mean, it's what we do for people who experience chronic major medical conditions. They get to come home and they have their disability pay and they get to relax and focus on their rehabilitation. We don't do that for people who just experience a traumatic psychiatric crisis. And so we want to be able to pay for their rent so that they can focus on their care, and that psychiatric crisis doesn't put them on the streets, frankly, because they've lost their rent, they've lost their job, they've lost their home, etc. So super excited about that. The other piece is, and I know you'll be familiar with this, is that we are finally submitting our pursuit for the IMD exclusion waiver. And that's true for both young people as well as adults. The thing I would really underscore is we're actually calling it our California Behavioral Health Community-Based Waiver. And we're doing that because one of the things that the counties who participate in the pilot or demonstration will have to document is that they are investing in a full continuum of care. And that they are taking those dollars that they would have had to spend on IMDs and investing it in community-based care. So really that is the visionary kind of, I don't want to say wrap up of Cal-AIM. I don't think you want to get me to give you an update on documentation reform, but I think it's the last kind of, those two pieces are the last two really big pieces. We also this year will be implementing our Justice Cal-AIM package. So that's our ability to go in and activate Medicaid 90 days prior to release. And we're going to get folks assessed, we're going to get folks engaged, and we're going to get folks placed into care directly coming home from our jails. So really, really excited about that piece too.
Okay, so there's one more question, actually two more questions now. So the question is, I have a question regarding these housing and facility options that will be essential if doing this work, if this is going to work. Santa Clara County and San Francisco are some of the most expensive areas to live in the entire country. How will staff be enticed to work and live in such expensive areas when it's so hard for them to buy a home and have a family? Will more money be required to be spent in these areas to attract mental health professionals to work in these facilities or supported housing options? Or is it possible that these housing options will be built in more affordable areas like Central Valley? Frankly, this won't work at all if you don't have quality facilities and housing options along with excellent staff members, doctors, case managers, nurses, therapists, etc.
Yeah, really, really excellent points. I don't disagree with the things that you're saying. As somebody who left the Bay Area because it was not a place that was affordable to be, I understand what you're saying. I do think what we have thought about is giving the counties some creativity and flexibility with some of their resources. What they choose to do to attract quality staff to a certain extent is within their purview. They can use, obviously, as I mentioned before, we are dedicating about $108 million a year to counties, just county behavioral health, to cover the cost of care in particular. That is not reimbursable. Maybe they decide to use some of that money to enhance salaries for care team participants, or as, a housing stipend. Like I've heard that that's something that is often offered in the education side of thing in the Greater Bay Area. I can't speak to some of the creativity that can happen at the local level. That's all very different in different communities, but I can say that there are some flexible funding sources out there. One would be, of course, the general fund that will be contributing to counties for the success of care, but also the MHSA is quite flexible. Maybe for those team members and care team members who are working with some of our most vulnerable, who are working on call 24/7, et cetera, maybe there can be some sort of a patch or an enhancement, or first in line to get the loan assumption dollars that have been dedicated to your particular county, those kind of creative thinking. And I really do think the county behavioral health directors are thinking about these things.
Yeah. Okay. All right. A final question here. I'm not an expert, but an experienced family friend of the mentally ill of 25 years who sees a need for a community-based housing situation with consumer buy-in and job engagement, etc., with family engagement and meaningful living. This needs to be a community with a friend and a family involvement for it to work. Is there a niche for a group of such people, families and friends in NAMI to form a mental health housing cooperative under this new CARE Act? Would we have support under this act? I want to start a community with inexpensive hookups for teardrop RVs for the severe mental health sufferers, loved ones. How can I do this under the act? It would be a sort of a short-term community when bouncing back and forth between periods of jail, crisis housing, and street living.
Well, I don't think it necessarily has to be anything that you pursue just under care. I'm not sure I completely know the scope of your vision, but I do know that, especially with behavioral health bridge housing, we want to get as creative as humanly possible. I love some of the things that I caught that you shared, which were about creating community for folks. Something that I really want us to explore more about what we can do at the state level to support it. But not everybody has to live in there's these gray areas between residential living, things that we license and certify and provide oversight of, and that's because we pay certain rates for people to live there, and really just a functional shared housing environment. And we've all seen it, right? It's how young people who go away to college support each other. They live in a shared living environment. It's happening more and more with our aging population. We really encourage that, right? It's a shared living environment. There's all sorts of research about, the last two generations are the only generations who didn't live in generational families, so within one home. So I think all of those are really great ideas, and you can feel comfortable sending an email even to that care address if you don't have my email, for me to maybe try to figure out other ways for you to get engaged and at least super knowledgeable about the dollars that are coming down the pipeline, so that to go to your county and say, hey, I know you're getting behavioral health bridge housing. I have this really great idea that I think is going to work for Santa Clara County. Can we talk it through? But I think when it comes to resolving the crisis that we have, I think we're all open to a lot of ideas and really need to think outside of the box. And for my friends and advocates here on the call, we've all been doing this work for a really long time. We have 4 more years of a leader who is deeply dedicated to this. And we want to make sure we make the most of all of those opportunities. I think even in a really challenging budget year, behavioral health did exceedingly well. We even got a lot of additional resources. So keep up those creative ideas, and you can always send them, and they'll get up my way. And so I'm happy to take creative ideas. And I have one suggestion before I run off and go get something to eat. But, I also would love to hear from chapters like you of things that we should be doing to support you in a role that you can be playing locally. I'll be talking to your state NAMI a little bit more about how we might be able to use the state NAMI to kind of facilitate some of that. But but you're really an important messenger. And we want to empower you to have the tools at your disposal to share that message and to share it accurately, because the last thing I wanted to say, if it didn't come across in the presentation directly, is that there's a lot of folks that care is not going to be the answer. So we have to use this as an opportunity to get them access to the right answer. We're going to put these individuals on the radar of county behavioral health, and we don't want to miss the opportunity to get them directed to the part of the system that does work for them, that is meant for them. And so you guys are a critical partner in that, and let us know how we can support you in achieving any of those goals.
So I think that I think that's about it. I don't see any other questions. So I just want to thank you so much, Stephanie, for coming on such a busy day and sharing all this information about the CARE Act and answering all our questions. I think this is a very, very important program, and NAMI has been very supportive of it. And we're really excited about it, when it gets implemented. So thanks again for coming in, and good luck with everything. And whenever you have any questions, or if you need any support, we're always there for you. So just want to let you know.
Thanks for having me. Everybody stay safe and check in on your loved ones. Yeah. We still have a lot of weather to get through.
Yeah.
Okay.
Thank you so much.
All right. Bye-bye.
Thanks everyone for joining us tonight.